Well, hello there. Welcome to another edition of the iTube Journal Club. I'm Chris Starr from the Weill Cornell Medical Center. And with me today is a good friend of mine, colleague, esteemed cataract and refractive surgeon, Rob Weinstock from the Eye Institute of West Florida. And of course, you're the director of refractive and cataract surgery there. You have a tremendous experience with these surgeries. And you're really a pioneer in a lot of ways. And there aren't that many people in the country right now who have femtosecond cataract. But you, and you're the only person I know, but there may be others, have two platforms in your office. The Victus from B&L and the LensX, correct?
Yep.
And so let's start this conversation by just getting a little bit of a feel from your personal experience about the two platforms. You don't have to necessarily say pros and cons of each, but sort of just how you're feeling about the two platforms.
Well, obviously, I've fully embraced refractive cataract surgery with a laser, and I have such an interest in this area of trying to. As many of us are trying to do, improve outcomes, take cataract surgery to the next level, provide better visual outcomes, more automation to the surgery, and better safety and better results for the patients. So it's a long story, but we do have two laser platforms. We've been working with the laser from Alcon, the LensX laser, which was the first to market for well over a year, and now for the past 4 to 5 months we've been working with the Victus laser. We're still using both lasers on a regular basis. They're very different machines. They both do a lot of similar features. They're both outstanding platforms. And the other two platforms, from what I've seen and gotten feedback from other users of those platforms, is nothing but positive reviews. So I think that in general, cataract surgeons can feel comfortable that this technology is extremely safe for patients. It's going to continue to make what we already do very good, make things even better. And the automation and elimination of surgical variables can really do nothing in the long term but benefit patients. And both these devices, I found, have been achieving those goals in my practice.
At this point, it's April 2013. As far as what they're approved for technically in the U.S., are they both approved for the same things right now, or is one? Are there different indications?
It's very interesting. The approvals are often different than what the actual softwares are doing. So, for example, the LensX is right now approved for capsulotomy for cataract surgery, arcuate incisions, wound construction, and lens fragmentation. It also happens to be approved. It's really not approved. It's cleared by the FDA, is the proper terminology for a 510K clearance for all these things. It's also cleared for LASIK flaps, but the software has not been released yet to do LASIK flaps, even though it's been cleared. So we're not doing LASIK flaps with the LensX at the moment, but that is on the short list of things that are coming for that device. The B&L device is a little bit different. It has approval for LASIK flaps, and the software is quite good and adequate for LASIK flaps. We're making very nice LASIK flaps with the Victus laser. In addition, the Victus has also been cleared for the capsulorhexis and the arcuate incisions, but not yet for fragmentation or wound construction. So this is a moving target, and even by the time this journal club is released, we may have changes in this, and that's how quickly things are moving in this particular field.
Yeah. So as it stands now that you have the two, and of course they are indicated for different things as it stands now, how do you determine what Mrs. Jones, which one of them Mrs. Jones is going to get?
Well, it's a tough question, and this is something that we're having to choose on a case-by-case basis. There are some cases of patients who have Fuchs dystrophy, very dense cataracts, ones where I know breaking up the lens with fragmentation is going to benefit that patient and reduced ultrasonic energy, reduced trauma to the eye. So those patients right now I'm moving on to the LensX. There's other patients that for example, the capsulotomy with the Victus is truly impressive. I mean, it's almost a 100% complete capsulorhexis each time, and it's just such a atraumatic procedure on the Victus laser with the docking mechanism that it's extremely easy and friendly to use for the patients, and I really enjoy using that platform too. So the other feature is that Sometimes we just get into routines, or we're doing a study where we're trying to take a look at a group of a subgroup patients. Like right now, we're working at refining nomograms for the Victus for the arcuates, because that's the most recently released software. So I'm doing a lot of treatments right now on the Victus so we can develop nomograms for the arcuate wounds, so surgeons have a good basis to start with when doing these arcuate incisions and correcting astigmatism on the cornea.
Yeah, let's talk about that, because I know you have some recent data that you just unveiled, and with an effort of automating, as you said earlier, automating, and that's a word that I like to hear, but sort of honing in on good nomograms for LRIs with the laser. We all know that making LRIs with blades, they certainly have value, but there's a lot of variability. A lot of people refer to it as an art, not a science. Yeah. One would think a femtosecond laser-created LRI would be more closer to science than art, but there's probably even then some, a little bit of art involved. And you are trying to make it a science. So tell me a little bit about the study and some of the results.
Well, the most recent study that I've been involved in, along with Dr. Sioni and Espiritu from the Philippines, is trying to do a prospective study with the LensX on some automation of nomograms based on preoperative biometry acquired data that's then fed into the LensX laser and is using a Holiday prescribed proprietary nomogram that will basically kind of take that step out of the surgeon of having to use a modified nomogram or come up with their own nomogram or call their colleague to ask what to do. Something to further reduce the variables that we see in arcuate incisions, because you're right. Traditionally, arcuates have been variable, because you've got the optical zone. It has to be accurate. The axis is another variable. Cyclotorsion comes into play when you talk about these, the depth of the cut. So you've got all these variables. So the more we can eliminate these variables and standardize all these things, the same depth cut. The other thing that this study we did showed is that, well, we actually took into account the surgically induced astigmatism from the laser wound, because everybody's laser wound is a little different size, different angle. So we took 30 cases, and we each of us, and looked at what our SIA was, and the formula takes into account the SIA and the preoperative astigmatism, and then a nomogram with a paired incisions is made, and we're just looking to see about astigmatism reduction. And we've put about 123 patients through this study combined, and we have data back on roughly 70 of these patients, and we're showing that it's great. The results have been great so far as a group. So far, we're looking at around 70% of our patients. We've had the astigmatism reduction down to less than half a diopter in about 70%. And up towards 90% of 3/4 diopter. And I think the average amount of corneal cylinder that we're starting with, including the induction from the surgically induced astigmatism, was 1.5 diopters. So I think we're moving towards this refinement of what we're doing. And we still don't have good registration. We still don't have a good way of docking the patient on any of these platforms that I've seen to where we're taking into account any cyclotorsion. And axis is so important,
it's everything,
just like with torics. So there is a lot of ground that still needs to be broken in terms of automating this, improving the outcomes, making sure that this laser, as sophisticated it is laying down these arcuates at the right zone and at the right axis.
I mean, it's amazing, and certainly one can skip forward in your head 5, 10, 15, 20 years at where this is really going. Right now, when I'm doing my surgical planning, I'm spending hours going through all of the Ks and the IOL master and the Pentacam and the Orbit, and just trying to, I'm crunching the numbers on paper and trying to figure out what's going to be best for my patient. What you're doing, and this is the seed of probably the future, and that is, like you said, automating and letting basically the machines, as it were. This is not the Matrix, but the machines making
Terminator.
The Terminator. The machines making decisions, but they're making good decisions because, as you said, the residual astigmatism was 0.5 or less, and without any hard, brain work on your part.
Exactly, and that, I think, and you're exactly right. I mean, the more complicated this gets as we chase Plano, and the more tools we have, and technology and devices, surgical planning becomes a burden. I mean, I can remember, and I still do, take home, cartons of charts in my trunk, throw out my back, just trying to get the charts to where I can, because I don't have time during the day to review all these charts and pick the lenses. So to take that burden off the surgeon and automate that process is something that's going to be a great benefit to us, and it's going to be standardized. It's going to, but be personalized too, because it's going to take into account where you place your wound. It's going to take into account the astigmatism that's induced by that, and the specific targeting, and just this global concept of, as you mentioned, automating surgery for us is going to help the patients. It's a changing environment. It's very different from what we're used to doing.
Yeah. Well, I want to thank you for being the pioneer here, because I don't have a femto yet. I'm going to get one certainly at some point in the future, and when I do, thanks to your hard work now, it'll be a lot easier adoption for me. So Rob, I want to thank you for being here, and I want to thank you for watching the iTube Journal Club.